Well, the Marvel study builds on the concept of leadless pacemakers. So the first publications were in 2015, where it was shown that you can in fact implant a pacemaker to achieve ventricular pacing without any intravascular leads, without a surgical incision, without a separate generator. So the entire process of the pacemaker is in about a 1.5 centimeter little pill kind of thing that goes in through the femoral vein and is implanted in the right ventricular apex. And those studies showed that you lowered the complication rates compared to traditional pacemakers by 51%, quite substantial, and had an excellent result in terms of achieving pacing, durable thresholds, durable sensing over longer periods of time. And in a portion of those patients, the device was implanted in patients who had intact sinus node function. So even though they benefited from the lower complication rates associated with leadless pacemakers, they lost atrioventricular synchrony. And losing AV synchrony has a poorer quality of life, a lower functional status, stroke volume or cardiac output actually is lower in patients who have ventricular pacing versus atrioventricular synchrony. So the question became, can we in fact achieve AV synchrony from a single device? And it was found that the accelerometer, the standard sensor in the pacemaker, had the capacity to not electrically sense atrial contraction, but mechanically sense it. So the accelerometer senses the acceleration in blood flow caused by atrial contraction. And if you could in fact sense that appropriately and consistently, you would achieve AV synchrony. And the study, Marvel, was designed to say, can this occur? So first there was the MOS and MOS2 trial, which showed that yes, I can sense it. And then Marvel closed the loop by implanting it in the patient and seeing what percentage of AV synchrony was achieved. And in fact, for the overall cohort, we were able to achieve AV synchrony 87% of the time in the cohort of patients. This was done in patients who had existing micro devices. So a software download had occurred in these patients. Some patients were implanted just that day, but there were patients who were implanted 40 months, whose software was downloaded 40 months after implantation. So it was a wide spectrum of when the device was implanted, but the software was downloaded into the patients, and it was basically a 24-hour study in which we walked the patient, we sat them, we did ultrasound, and we looked at a Holter monitor, which was simultaneously on the patient, and tracked P waves and determined what percentage of atrioventricular synchrony did we in fact achieve. This technology allowed us to achieve AV synchrony in up to 87% of the time. In patients with complete AV block, we got it 80% of the time. In patients who had intact atrioventricular conduction, the algorithm did not interfere with normal conduction. We showed an incredibly low rate of complications. There were no pauses, there was no syncope, there were no complaints of pacemaker syndrome because of this ventricular pacing. So we showed that yes, this concept of mechanical sensing could in fact be achieved in a high percentage of patients with a very low complication rate. This was really a feasibility trial. Can we in fact sense it enough to have a high percentage of atrioventricular pacing? But now we have to test it. We have to test it when patients are walking upstairs, when they're jumping up and down, because the sensor in the accelerometer will sense everything. Not necessarily only the things that are going on inside the heart. So can we filter out the noise to achieve a high enough rate of AV synchrony? What percentage of AV synchrony is really needed to make people better long term? Those are all questions we have to do. And in addition to that, we have to create a device because the technology of the existing Micra is not designed to handle all this information. It's a big drain on the battery. So we need to be able to create a device that in fact can handle this amount of information with a longevity that's acceptable. You know, I think this is one of the multiple steps that are occurring to get out of the intravascular space. We have subcutaneous defibrillators because we understand that there are substantial long-term risks with intravascular devices. So I think the trend of all of cardiology in some respects is more and more non-invasive or less invasive interventions and devices. And I believe that once we get a dual chamber device, so a leadless pacemaker in the atrium and a leadless pacemaker in the ventricle, that will substantially enhance the field, and I think industry is heading towards that. I think we could think of leadless devices in the left side of the heart or epicardially to potentially achieve resynchronization. I think there's a potential that leadless devices can communicate with a subcutaneous defibrillator. So yes, I think the future is leadless. I do.